So my name is Fichera. I'm an assistant professor at Worcester Polytechnic Institute. I gotta say, it's really hard for me to speak immediately after Dr. Alterowitz. His research is amazing, and he and his team have been so successful. And I didn't even have a fraction of his success in my career until now. I'm at a much, much earlier stage. I guess I'm saying this because I'm trying to manage expectations a little bit for the next 30 minutes. But moving right along. So this is WPI. For those of you who have never heard of it before, we are a small science and engineering school located in central Massachusetts, about an hour away from Boston. Historically, we've been an undergraduate school, but in recent years, our research output has increased quite a bit. And in fact, our graduate population is increasing a lot. As of today, we have about 6,000 students, and about 1,800 of them are graduate, and the majority of them are in the robotics program, which I would say is the one thing that is probably the reason why we are known both nationally and overseas. WPI was home to the first undergraduate robotics engineering program back in 2007. And since then, we have grown a lot. As of today, we have about 21 faculty in our department, and we do research in all aspects of robotics, including surgical robotics. But really, you name any type of robot, we most likely have it. The reason why I joined WPI is that we have this center called Practice Point, where we essentially have a replica, a mock-up of different clinical environments where you can test your robots without having to use machinery or rooms or facilities in the hospital. We can do testing up to the preclinical stage. The pictures here are showing some of our facilities. We have, among other things, a full clinical MRI. One of my colleagues here, Greg Fisher, is a pioneer of MRI-compatible robots. But we really do have a cluster here of medical and surgical robotics faculty, including people that do research into imaging, others that do research into magnetics, and so on and so forth. This is my research platform here at WPI. I do research, my students and I do research in two main areas. On the left side is what we call energy-based surgery. So what we do is we look at ways in which energy-based instruments interact with biological tissue, and we try to develop modeling and control algorithms to optimize the effects that these instruments have. And on the right side of the screen, we have continuum surgical robots. Now, if you're watching the presentation from Dr. Alterowitz, I don't need to introduce these types of robots for you. Typically, projects in our laboratory involve some combination of permutation of these two main trusts. And I would like to start by talking to you about one project that has been, for which we have received funding from the NIH, which I believe best combines these two fundamental research trusts. And this project involves doing surgery of the vocal folds, surgery of the voice box in the office. This is a collaboration between my group at WPI and Dr. Thomas Carroll at Brigham and Women's Hospital in Boston. And effectively, what we're trying to do is to enhance the way in which pathologies of the voice box are treated in an office setting. If you're not familiar with, treatment of the voice box, this is one way of treating them. Essentially, if people present with, let's say, a benign tumor of the vocal folds, the physician would pass an endoscope through the nose down into the voice box, and then deploy an optical fiber to apply laser pulses on the lesion, and effectively using the heat produced by the laser to necrotize the tissue and essentially remove the tumors this way. Now, one of the limitations of these procedures, among others, is that it's currently very hard to control the aiming of the laser, because the only way to do that really is to control the bending of the scope. And so when the physician is into the larynx, it may be hard to keep the laser on target. And I hope you're able to see the video that I'm playing right now, but this is showing a natural procedure where the physician is really trying to wrestling with the scope. Of course, there is also patient movement going on because people, patients are awake. And it is really hard because of all this to keep the laser on target, which is where we come in. So this is me testing a new type of optical fiber we have developed in my laboratory with a model, three-dimensional model of the voice box. And in this video I'm playing, what I'm doing is I'm using this new bendable optical fiber that we can use to target lesions in places that would normally be hard to reach, precisely because of the inability to control the steering of the optical fiber. We have developed this device together with Dr. Carroll, as I said, with funding with the NIH. And really the secret sauce of this device, what makes the bending of the optical fiber possible, is these very tiny 1 millimeter in diameter notched nitinol sheath that carries the optical fiber, and that can be controlled remotely to provide essentially fiber steering at the distal tip. This is the work of my recently graduated PhD student, Alex Chiluisa. We describe this work in a 2022 IROS paper, which you can access by scanning the QR code below. One of the interesting aspects of this work that I like to emphasize is the fact that, as I said, the notched tube wrist is really the secret sauce. And we can create notched wrists that can bend according to different geometries. Sometimes, depending on the anatomy, you may need to have more distal bending. Some other times it may be beneficial to have more proximal bending. And so this is something that we have actually explored in our group. These notched tube wrists, the way they work is essentially we have these sheets of nickel titanium, and we use a laser to create asymmetric notches into them. And then we attach a wire to the tip of the instrument that is pulled proximally to create the bending. The asymmetric pattern is beneficial in this type of applications for two reasons. The first one is that the device can be bent, can be articulated with a single wire, which of course enables us to create all like these instruments in a very tiny form factor. The other benefit is that with the asymmetric notches, we can create very tight curvatures, which would not be possible if, let's say, if the notches were symmetric, as it is the case in traditional endoscopes. And the other thing that I said we can do is we have actually developed mechanics models that enable us to create different bending geometries. And so what we did specifically for this voice box problem was we looked at simulation to find out exactly one bending pattern that was most beneficial for vocal folds. And to enhance surgical access in this part of the body. What you are seeing on the screen right now is one of these simulations. The blue shape represents the anatomy of the voice box that we have reconstructed in 3 dimensions from a micro CT scan of a cadaver. And then the simulation, what is happening there is essentially like a computer moving an endoscope with an optical fiber, one of the optical fibers we have designed sticking through. And every time the optical fiber is able to get close enough to the tissue, then we simulate the application of laser pulses and the tissue turns yellow. And what that means is that that part of the tissue is now reachable, and we mark it as accessible surgically. And what we have found is that if we compare the access granted by our steerable fiber versus what surgeons can access, with the traditional straight fibers they currently have in clinical use, then we can increase access nearly 2.5 times. And so in the long run, we hope that once we translate this clinically, this will help physicians treat many more patients that right now wouldn't even be eligible or for office treatment. So And this is one of the things I'm mostly proud of. The research, we have also discussed it in a recent issue, in an article that appeared on a recent issue of the laryngoscope. Those of you who are in the ENT part of the ENT community will certainly know this journal, and they featured our research on their cover page. Now, we brought the laser into the body. Now we need to control what the laser is doing. So this is where things get interesting because, traditionally, whenever I'm talking to an audience of like a general audience, what they say is, tell me what is, in your mind, a quintessential surgeon instrument. And everybody says, of course, it's the scalpel. Well, if you're using a laser works nothing like a traditional surgical instrument, so to speak. So you have to rethink the way in which, whatever models you have in your mind of how your tool is interacting with the tissue. Just like, the scalpel will normally use mechanical force to create cuts. The laser can also create cuts, but it is doing that using a different mechanism. And typically that is a thermal mechanism. And if we don't really know how to tune the operational parameters of the laser, we can achieve completely different effects, as shown by this figure here at the bottom, which is actually taken from I forgot to add the reference here. It's actually the a handbook of laser tissue interactions by Markov Niemts. And even though I'm not a doctor, I certainly recognize that, this is not a good outcome. There is a lot of carbonization here. This is certainly undesirable. Whereas this cut here at the left seems a little bit more acceptable. So we were saying it's a thermal dynamics we are trying to work with. So as roboticists, this is something that I speaking for my communities, this is something that we are not really used to controlling. Whenever people think about robots, and this includes surgical robots, we as roboticists know very well how to control the kind of forces that the robot is applying to the environment, the forces that the robot is applying to the tissue. Why? Because, well, that's really part of our basic training as roboticists. Any roboticist, anyone with a degree in robotics these days has taken a fundamental course in robot dynamics. That's part of the core curriculum, and that's what they teach us. But when the tool that the robot is manipulating is an energy device, that type of physics that the robot is trying to control is completely different, and they don't teach us that. And that's where my research, that's the knowledge gap that my research is trying to fill. So what we're doing is we are building physical models, trying to capture the interaction between energy instrumentation, including lasers, and biological tissue, and then enabling robots to control these interactions. Those of you who have some familiarity with heat propagation or laser tissue interactions will certainly recognize the equation at the bottom of this screen. This is the traditional heat equation that describes how heat propagates in solids. And in first approximation, this is oftentimes how laser tissue interactions are modeled. The idea is that the laser is absorbed into the tissue and create some localized temperature rise that is essentially like the concentration of heat, which then dissipates through the surrounding tissue following this equation over here. What makes these kind of thermal dynamics challenging to control, both for humans and robots, is the fact that it can be really hard to predict or to know how strongly the laser will absorb, how strongly the tissue will absorb the laser. The second equation, the one at the bottom of this screen, is giving us a very simple model of that. And the key parameter here is this mu A. What this equation is telling us essentially is that the total amount of heat that we are going to deposit into the tissue is given by the product between I, which is the intensity of the laser. So think about, increasing the power of the laser. That essentially increases the I. But then there is also this mu A, which is called the coefficient of absorption. And it is a parameter that is a function of both the type of tissue and the type of laser. Some tissues will absorb more than others, certain wavelengths. And it is really hard to know a priori what this mu A is, which in turn makes it really hard to know exactly how much heat we are adding to our tissue. And once again, I'm not the first one to describe these issues. In fact, I like to quote this review paper from Stephen Jacques from 2013. Mu A's, values of the coefficient of absorption, have been studied, have been documented in the literature on a variety of different tissues. But then if you have a patient in the operating room and you need to do treatment planning on them, would you be confident using a tabulated value from the literature? And he goes on saying, variations in mu A are significant, even from person to person, site to site, and even from time to time. Some lasers are strongly absorbed by the water present in the tissue. So sometimes even something like the level of like a patient's level of hydration can drastically change this value of mu A. And so how do we deal with this? This seems to be a roadblock on the way towards trying to automatically controlling these laser tissue interactions. Well, I partnered with a colleague of mine here at WPI, Dr. Andre Arnold, who is an expert in statistical state estimation. And we came up with this concept that we call virtual palpation. It's inspired by palpation that the surgeon would normally do before a procedure to feel the anatomy and perceive where things are. We call it virtual palpation because in this case, we're not really touching the tissue. We're using low pulse laser beams to create a thermal response and then measure these thermal responses. And based on the sensor data, based on the observation of the temperature increase, we back calculate the mu A, or the coefficient of absorption. And we do this using a new type of ensemble Kalman filter, which is a type of statistical state estimation method that she has developed. And we have done some experiments that we have disseminated in a journal paper that you can access by scanning the QR code at the bottom of this screen. And what we found is interesting. So there are a number of figures here, but I would say I would love you to focus on the one at the bottom left. What this plot is showing is that over time, as we are applying these laser pulses, the filter output is converging onto the actual unknown true value of mu A. So in this plot, the dashed black line is the true value of the coefficient of absorption that our filter doesn't know. We apply a laser pulse, and the solid red line is the filter estimation. And of course, the filter doesn't know exactly what that underlying value is. So it will never give us a certain measure. It will give us an estimation, which is a solid red line, with some confidence bounds, which are the dashed red lines. So essentially, it's a distribution of probability we are playing with. But over time, these confidence bounds get smaller and smaller and smaller, which means that the filter becomes increasingly confident about its own estimation. So this is very promising, and we are now working on implementing these in real hardware and doing this and validating this approach with real tissue. What can we do once we know the mu A, or at least we have a better idea what the mu A is? Well, we can control the tissue temperature. We can adjust the laser parameters, the laser inputs, to achieve consistent results, to achieve consistent heating. My PhD student, Nicolas Pacheco, recently published a journal paper where essentially what he has done is he has shown that it is possible to control the focusing of a laser to achieve controlled heating. And we do that by using adaptive control, which is a type of automatic control technique someone would use when trying to control a system whose parameters are not entirely known with certainty, such as the case of laser tissue interactions. And once again, we are really excited about the results that Nick has obtained, because we've done experiments where we have put different types of tissues in front of a robot manipulating an optical fiber. And the reason for using different type of tissues was exactly to try to create a variability in that mu a, in that absorption coefficient. Of course, the robot doesn't know anything about the type of tissue it is facing. All the robot is told to do is to hit the tissue because maybe we want to thermally necrotize it. And the good news is that regardless of the type of tissue the robot is facing, it is able to consistently create a temperature, regardless of the mu a, regardless of the type of tissue, with average tracking error in the order of 1 to 2 Celsius degrees. So hopefully this is showing some of the potential of these statistical estimation methods. We now are able to control very precisely what the laser is doing, even without any prior knowledge of the type of tissue, or without any a priori knowledge of the control that we need to use, the parameters of the controller we need to use. Another thing we can do, in addition to hitting the tissue, is also cutting it. This is a little bit older work I have done earlier in my career. During my PhD, I was tasked with creating autonomous systems for laser cutting. And the way this worked was by essentially collecting data, capturing how different parameters affect laser penetration depth, and then using all this data to build machine learning models that are going to predict how the tissue is going to react based on certain laser inputs. And so we did some experiments. Once again, this is a little bit older work now, but we did some experiments where we showed that it is possible to pre-plan incision or ablation of an entire area of tissue, and then we can let a robot do the scanning and remove the tissue autonomously. And we were able to achieve ablation accuracies of in the order of 0.15, 0.2 millimeters. In summary, I'll move on to conclusion. I'm really excited about the future of energy-based instruments. Of course, lasers are a big component of my research. One of the things I like to emphasize is that I didn't start my research just out of the pure desire of pushing lasers into surgery. I like to say that I had a time machine when I started my research, in hindsight, and by that I don't mean to say that I had a DeLorean or any other type of form of time machine. I simply read papers, and in particular, I read this paper from 2007 from Steve Zeitels and colleagues at here in Boston. They are ENTs and they are here in Boston. And this paper, once again, published in 2007, reported a set of forecasts that they anticipated would have become true by the year 2020. We're in 2024 now. But it was very inspiring for me to read this paper at the time because it contained some of the elements that I have since used to create and chart my own research platform. And in particular, I would like to call out this one. They said in 2007, inevitably the advantages of fully automated surgical treatments may be achieved. For example, a robot laser for laryngeal cancer surgery could be a device capable of finding and vaporizing tumor based on programmable criteria, instructed to detect and avoid blood vessels of a certain size, and to query the surgeon where certain criteria are not met. True surgical robots will almost certainly be developed and deployed eventually. So most of my research is trying to enable this vision. And once again, the reason why I wanted to emphasize this connection with this paper is the fact that we as engineers, we can only do so much in surgical robotics. Eventually, actually, even not only eventually, but right off the start, we get lots of inputs from the medical community, and inevitably, we can only have an impact if the clinical community and we engineers work together to tackle the problems that the clinical community is facing. With that, I would like to thank my team here at WPI and also the funding sources that have enabled us to conduct our research, including the NIH and the NSF. And I will be happy to take questions.
Thank you. That was fascinating, even for a vascular surgeon. So one of my questions for you is that as you start ablating and the surface properties change, like when I take an electrocautery, it starts off looking at nice liver, and then all of a sudden there's this big eschar on top of it. Can you compensate for that? I mean, can that be built back into the robot?
That is a great question, and that's exactly one of the elements of novelty, I would say, that we are trying to bring to fruition here. When I talked about, statistical state estimation of tissue properties, and that algorithm that we are using is one that is able to sort of track how the tissue properties are changing over time. Which is, I would say, probably the main element of novelty that my colleague Andre Arnold is bringing into this work. So we haven't demonstrated this yet in experimentally. We have only done it in simulation, but yes, ultimately that's where we're headed.
Thank you.
And I believe we had one question from the audience as well. It was, how do you vent out ablation products from the airway?
Oh, how do we remove the ablation products from the airway?
Correct.
Right, so usually the way that's done is with a suction mechanism that takes, so if it's aerosols, then it's relatively straightforward because you would normally just suck the air out. If it's solids, let's say that you have tissue particles and stuff flying around. Once again, it depends on the size of the debris. It may or may not be feasible to do that with a suction mechanism. If they are like larger things, a forceps may be necessary.
Wonderful. Well, Dr. Fichera, thank you very much for joining us this morning. And again, I look forward to seeing you again soon. Thank you.